Good evening, everybody, and welcome to a night in with Newlife, our fertility webinar series. My name's Chris Russell. I'm one of the fertility specialists with Newlife IVF, and I'm very glad to be here tonight. First of all, it's been a great day for fertility treatment in Victoria and Australia because the federal government has announced that fertility treatment can restart, which is very exciting for all of us, our patients in particular. The team has been working really hard over the last few weeks to make sure that the laboratory is all ready to go and the nurses are ready. So anyone who's ready to start treatment, please get in contact with us tomorrow and we'll give you instructions on how to get started as quickly as possible. Tonight, we're very lucky to have with us another fertility specialist, not just me, but Dr. Amber Kennedy, who is a fertility, one of our specialists practicing in East Melbourne. And together, Amber and I are going to take you through an IVF cycle and talk to you about what it is and what happens and what you can expect from it. As always, we really enjoy getting questions, and you will notice that if you scroll down to the bottom of the screen, you'll see a question and answer section, and if you click on that, you'll be able to ask us any questions you like, and we'll get to those at the end of the presentation. But without any further ado, let's get started. And like I mentioned, we're going to be talking about IVF tonight. So the things we're going to try and cover for you is who is IVF for? Then we're going to move on to what are the steps in an IVF cycle. Initially the part that involves collecting eggs and creating embryos. We'll talk about frozen cycles, which is the transfer of embryos that have been created previously. I'm going to talk to you, so those first topics will be Amber, then I'll talk to you about what we do when IVF doesn't go exactly to plan. We'll also chat a little bit about IVF success rates, and then of course we'll take your questions at the end. So IVF, who is it for? So primarily IVF used to be for women who had blocked fallopian tubes because IVF totally negates the need for fallopian tubes. So you could have none at all and IVF would work very well. Moving on from that, over time, it became a very good treatment for men who had abnormalities of sperm. So it was a very good treatment for men with poor sperm quality. What we increasingly do IVF for is when other fertility treatments haven't worked. So we've talked to you over the last few weeks about ovulation induction and insemination. And when those fail, we know that we've got IVF in our back pocket, and it's a very effective treatment in that group of patients as well. You can add to that group people who don't know why they're not getting pregnant. So we all of us, all the doctors at Newlife are constantly seeing patients who are in their mid to late 30s who've been trying for a period of time. We don't always find a reason, but sometimes the answer to helping you get a baby is to undergo IVF. The other common reason is utilising donor sperm or eggs. So whilst donor sperm can be used by insemination, it's quite a bit more efficient and much higher success rates to use donor sperm for IVF. Likewise, if you are using donor eggs, the only way you can use those eggs is by undergoing an IVF cycle. So to undergo IVF, what do you actually need? And it's no different to any pregnancy. You need sperm, you need eggs and a uterus. So as long as you've got those things, IVF is a suitable treatment. Before starting IVF, I think it's really important to consider a couple of things. And some of those are regulatory things. Before starting, you must undergo counselling in Victoria. You must undergo police checks and child protection orders. And whilst we did hear, it might have been 1 or 2 months ago, that the requirement for police checks and child protection orders was going to be lifted, our government has been a little bit distracted as late, and we're waiting for that to become the law, and we expect that to happen reasonably soon. But we would think that's probably a month or two away. So at least I would say, and so anyone planning IVF treatment, don't wait for that requirement to disappear, because I think it'll be with us for quite some time, particularly given how things are going at the moment. The other is informed financial consent. We always make sure our patients understand the fees before they start their treatment, and we always make sure at Newlife that you sit down with one of our finance team to discuss the fees. which brings me sort of to my next point. You should really consider where you have your treatment. And there are a number of clinics in Victoria, and you really have to delve a little bit more deeply to figure out which are the better ones. And it can be very difficult as a patient, but what you've got to do is look at, in particular, what the laboratory has to offer, and look at what your IVF specialist has to offer. And at Newlife, we're very, very comfortable with patients doing that, because we are really well positioned to compare very favourably. I always recommend that patients discuss their treatment in depth with their fertility specialist, and make sure you understand the treatment. That's a really important point. If the treatment doesn't make sense to you, maybe it doesn't make sense at all. So if you're hearing recommendations that seems a little strange, maybe that's a time to think a bit more broadly about your treatment and whether you're taking the right steps. So with that in mind, I now invite Dr. Amber Kennedy to take you through the steps of an IVF cycle, and I'll be back later in the presentation.
Hello, everyone. Thanks, Chris, and thanks for tuning in again tonight. So I'm going to walk you through the basic steps in an IVF cycle. So the timeline of an IVF cycle is quite analogous to your natural menstrual cycle. On day one, the day one of your period, the cycle begins. The stimulation phase begins on day 2, and usually that lasts for about 10 days, but this can be quite variable. We usually aim to perform an egg retrieval procedure around about day 13, and on the same day we fertilise the eggs in the lab. We then need to grow or culture the embryo for approximately 5 days, and then we put the embryo back where it belongs, inside the uterus. And the cycle ends with a pregnancy test at the end. Now I'm going to talk through each one of these steps in detail. So to begin with the stimulation phase, as I said, that begins on day 2, where you commence daily injections of hormones that hopefully stimulate the ovaries to produce many eggs at once. These injections are the same hormones that your body produces each month in order to release a single egg, sometimes 2, but usually a single egg. But in higher doses, this stimulates the ovaries to produce many eggs at once. These injections can be given by yourself. You can self-inject, or your partner can help you. Then on day 6, a second type of injection is commenced to block ovulation. We don't want all of those eggs that you are developing to be released prematurely. And then on day 8, we commence monitoring to check the progress, and this is done both by ultrasound and blood tests. This monitoring can be done in various locations throughout Melbourne. And what we're looking for is development of these follicles here, these fluid-filled sacs, which contain the eggs in the ovaries. Once the follicles have developed to a sufficient size, you are ready for the egg retrieval. Just prior to the egg retrieval, a third type of injection called the trigger is administered, and this is given 36 hours exactly before the scheduled egg retrieval. And our IVF nurses will ensure that you know exactly when to take your trigger injection. The egg retrieval procedure is done in hospital in Box Hill under a light anaesthetic, and it usually takes 20 minutes or less. It is performed via ultrasound guidance, and we use a fine needle to aspirate each one of those fluid-filled follicles and collect the egg. You can usually go home about 90 minutes after the procedure, and it does take a day or 2 to recover, but we usually find that Panadol is sufficient for pain relief. On the same day as the egg collection, we will then, in the laboratory, fertilise the eggs with sperm. This can be done either via conventional in vitro fertilisation methods or via ICSI or microinjection of the sperm. We can use a fresh sperm sample, which is collected on the day, or we can use frozen sperm, which has been in storage. We then do a successive fertilisation check the next morning. So conventional in vitro fertilisation is where the egg and the sperm are mixed together in a fertilisation well. This image down here, we see the large cell, which is the oocyte or the egg, surrounded by many, many sperm, each one competing to be the chosen one. And eventually one of those sperm will bind the egg and fertilise it. This method requires good quality sperm and good numbers of sperm and has the highest live birth rate. There is some limitations, particularly with pre-gestational genetic testing using this fertilisation method, as the excess sperm can contaminate this sample for genetic testing. There is a small chance of failed fertilisation with this method. On the other hand, ICSI or microinjection of the sperm can be used to utilise very poor sperm samples. So just a single sperm is required to fertilise each egg, and it is deliberately injected inside of the egg cell. All forms of pre-gestational testing are possible because there's no DNA contamination. And we can do, if necessary, advanced selection techniques to ensure that the right sperm is selected. So once we've successfully fertilised your egg, we need to grow the embryo. This is done in an Embryoscope incubator. And not all laboratories will utilise this technology, but we believe that this is the best for the health of your embryo. So this incubator has an inbuilt time-lapse photography system that will take a photo of the embryo every 5 to 10 minutes and allows real-time, detailed assessment of the growth and development of your embryo. All the while the embryo is remaining in a low oxygen at the perfect temperature and minimises the handling and the disturbance to the embryo. We do use a sequential culture medium, which means that as the needs of, or the nutritional needs of the embryo changes over time, we adjust the fluid that the embryo is bathed in. Now, I thought you might like to see this video of one of our embryos, which has undergone fertilisation via ICSI. You can just appreciate the magic that occurs inside the Embryoscope. This embryo is developing nicely. The cells are dividing. It's now a cleavage state embryo. And it will continue to develop by day 5 into a lovely blastocyst seen there. And that's exactly what we want to see. So each egg that we collect at egg collection has the chance of developing into a lovely day 5 blastocyst, although unfortunately this doesn't happen all the time. Early on there could be failed fertilisation of the egg. The embryo's development can arrest or the embryo can degenerate. The embryo can continue to develop in an abnormal way or a disorganised way. And that final outcome is assessed on day 5 or 6. At which point a normal embryo will be selected for transfer or frozen. And the embryos that are abnormal will then be discarded. So in preparation for your embryo transfer, your hormonal injections will cease and you will start progesterone supplementation. The embryo transfer is like the egg retrieval performed in Box Hill. However, this is just a 5-minute procedure. There's no anaesthetic required. We do a consultation on the day with the embryologist so that you can see how your embryo has progressed during its culture. And the specialist will perform under ultrasound guidance an embryo transfer where the embryo is deliberately placed in the right place inside the endometrial cavity. You can go back to work on the same day straight away. And finally, 2 weeks later, the outcome of the cycle is assessed with a pregnancy test. And this is done or scheduled 16 days after the trigger injection, where you'll be approximately 4 weeks pregnant. If the blood test is positive, then that means you are pregnant, which is fantastic. And we would schedule a 5-week blood test, which is a routine pregnancy blood panel, and then a 7-week ultrasound where hopefully you'll see the first heartbeat. You'll then have a review with your IVF specialist and transition on to antenatal care or pregnancy care. If you're not pregnant, you will also have a review with your specialist to discuss the cycle and what happened in the cycle and the next steps. And with that, I will pass on to Chris, who's going to finish off.
Thank you, Amber. So as Amber was just discussing, as we adjust the camera a little bit, at the end of an IVF cycle, if you're not pregnant, the first thing we consider is that you might have some embryos stored from the treatment that are available for you to use over the months that follow. And transferring a frozen embryo is very much easier than collecting eggs and growing the embryos in the first place. All we need to do is, and like Amber said, you know, it very much mimics a normal menstrual cycle. So what we do is we wait for a period to start, and then we do some testing to see when you ovulate. And the reason we do that is because the transfer of the embryo is timed to when you naturally ovulate. So we'd start doing some tests around about day 8 to day 9 of your cycle. They are sometimes blood tests, they're sometimes urine tests, they are sometimes ultrasounds. It just depends on the circumstances. However those tests occur, what they are for is to pinpoint the time of ovulation. Once the timing of ovulation is pinpointed, we book you to have an embryo transferred either 5 or 6 days after that test. And what that means is that you might recall from what Amber was saying that the embryos grow in our beautiful Embryoscope for about 5 or 6 days. So when we take out the embryo and thaw it, the embryo is perfectly in sync with the lining of your uterus. The embryo transfer procedure itself is identical to the transfer that you would have when the embryos are transferred fresh. That is, you come in, it's a very brief visit to the laboratory, we pop the embryo in, you go back to work and continue your day. Again, we do a pregnancy test around about 14 to 16 days after ovulation. If you're pregnant, great. If you're not, then we make plans for what to do next. Sometimes though, you don't have any embryos left after you have your initial embryo transfer. So what we then do is we really closely analyse how the treatment cycle has gone and make some decisions about where to next. And I thought what I would do is take you through some of the issues that we come across during IVF. Some of those things are, some of the issues we pick up are picked up during the treatment cycle, so before egg collection. Some of them aren't known till later. So I'll sort of explain what we do when those things happen. But I guess during the stimulation, we want to get the perfect number of eggs. And sometimes, despite our best efforts and our experience, we find that too few eggs grow, or less, or lower egg numbers than we would like. Sometimes there's two sort of situations where that will alter what we do in that situation. One is if you're a patient who we don't expect to get a lot of eggs, we may just continue with the egg collection and make the best, do the best we can with the number of eggs we're able to collect. Occasionally, though, we have patients who have potential to grow many more eggs than we see growing, and in that case, we might say, look, let's cancel the cycle. Let's try again next month with different dosages of medication so that we can get the maximum number of eggs possible for that individual patient. So occasionally, it really depends on your individual situation, what we do if too few eggs are growing. Occasionally, we have too many eggs grow, and you might well say, is that a problem? Well, yes and no. It's a problem if you don't know about it. If you do know about it and you can prepare, then it's not always a bad thing. One of the things we're very wary of is a thing called hyperstimulation syndrome, and that's OHSS, which is listed down there, and that can be a life-threatening condition. So our number one job as fertility specialists is to make sure patients don't get hyperstimulation syndrome. And the way we do that is we monitor the cycle very closely, and if there are 17 or more eggs growing, we tend to change the cycle a little bit. We still go ahead and collect your eggs, and we fertilise your eggs, and we grow them in a laboratory, but we alter the trigger injection. You might remember there's a trigger injection that takes place 36 hours before the egg collection. We change the type of trigger injection so that it matures your eggs beautifully, but it totally prevents you from getting hyperstimulation syndrome. The only issue with doing that is that we cannot do a fresh embryo transfer. So all of your embryos will be grown in the laboratory as usual. And when we get to the stage that they've developed into blastocysts, none of them will be transferred. They'll all be frozen for use at a later date. As you can imagine, if you do have a lot of eggs and a lot of eggs collected, we do tend to do quite well from the point of view that if you start with a lot of eggs, you are likely to get a good number of blastocysts frozen. So often it's, as it says, is that a problem? Well, it's a bit of a problem, but it's not always, because it tends to suggest you might have a good outcome in the end. I guess other things that are really important are to discuss side effects of the treatment. And we do have some patients who experience bloating in their abdomen during the treatment, and that's from enlargement of their ovaries, changes in the fluid balance of their body, so that there's a little bit more fluid accumulating in their belly. Equally, though, some patients never experience those things. Some people breeze through IVF without symptoms. I'm always asked, how does it affect my mental health? Will it make me anxious? Will it make me depressed? Will it make me cry? And again, everyone's a little bit different. Sometimes IVF does do those things. It's always very hard to know, is it the IVF medication? Is it the IVF process that's doing it? Or is it the situation you're in where you're desperate to have a baby and you want everything to go well? It's the most important thing you'll ever do in your life. All of those things often heighten your feelings during an IVF cycle. There's also non-specific things like headaches, things like nausea. Any medication can cause those things. And as a consequence, during the stimulation phase, some people do experience those side effects. But it's important to say that many, and in fact, the vast majority, don't experience these side effects at all. At the egg retrieval, it's an operation, and we're passing a needle into your ovary to take the eggs out. So as you can imagine, one of the side effects afterwards is that there's a little bit of pain. It's not normally serious, and usually patients are able to go back to work the next day, and if not, the day after. And generally, the only pain relief that's required is Panadol, simple things like Panadol. We often encourage you to pop on a heat pack, have a little bit of a rest, and generally the recovery is quite good. After a normal egg collection, there is a little bit of bleeding, but it's normally very light. It's often spotting and very rarely any more than that. The important thing is it's not from your uterus, it's not from the lining of your uterus, so you don't need to be concerned about having an embryo transfer if there is a little bit of bleeding for a day or so after. Important bleeding though, and I've sort of written internal bleeding there, that is a rare complication of egg collection. We see it probably 1 out of every 500 egg collections, and that can be enough for you to be perhaps have additional pain afterwards, sometimes admitted to hospital, and occasionally you need an operation to correct the bleeding. However, in my experience, I've never seen anyone lose an ovary as a result of that internal bleeding, and generally, if it ever does make it as far as surgery to correct the bleeding, it actually has usually already stopped by the time we get there, and it's just a matter of getting the blood out, and it's a very quick recovery out of that. But it is very rare, I hasten to add. Infection is possible with any operation, and we usually expect the rate of infection from an egg collection or an egg retrieval to run at, again, about 1 in 500 egg retrievals. It's a little bit more common in patients with endometriosis, and in those patients, we often give them antibiotics during at the time of egg retrieval to reduce the chance of infection. This is where things get a little bit more complicated. So once we take your eggs out and put them together with the sperm, we're sort of working in the laboratory setting, and that's where we get it becomes a little bit more complicated analysing what happens. So you can get issues with fertilisation of your eggs. And Amber mentioned that there are 2 ways of fertilising eggs. One is conventional IVF, the other is ICSI microinjection. With conventional IVF, you can get a thing called a failed fertilisation, and that's where, totally out of the blue, for no apparent reason, we put the sperm and the egg together and nothing at all happens. And when we check the next day, none of the eggs are fertilised. It seems on the surface to be a complete disaster, and it's always devastating for the patients when this happens. It doesn't happen commonly. It's only about 1 or 2% of cycles where conventional IVF is used. And when I do discuss that with patients, the obvious thing is that next time you do ICSI, and that completely solves all your problems. And patients are always really worried afterwards when they do ICSI for the first time. They think, oh my God, this isn't going to work either. But the reality is ICSI is a really effective treatment when this happens. Once the eggs just going back a step, sometimes even with ICSI, we notice that fertilisation rates aren't quite as high as we want, that not as many of the eggs are fertilised. And if that's the case, we sort of try and get some information why. We try and analyse whether it's a sperm problem or whether it's an egg problem. One of the nice things we do at Newlife IVF is we use a Polscope, which is an additional piece of equipment in the laboratory that's able to analyse the condition of the egg as the sperm goes in, and that gives us really important information. And when I mentioned at the start, it's really important to consider where you do your treatment. This is one of the things that Newlife does as standard treatment that helps patients making decisions about their treatment. So we hope to get some information about whether it's a sperm problem or whether it's an egg problem, and then we can make alterations to the treatment. If it's an egg issue, we can do some things during the stimulation or in the lead up to the stimulation. If it's a sperm issue, we might have to consider selecting the sperm slightly differently. Now, I'm not going to go into any detail at all on that tonight. We've got a webinar in a few weeks that will go over all these things in quite a bit of detail. But I would say that when there are issues in the laboratory with how the sperm or the eggs and the embryos develop, it's very much patient specific. So it's very hard to give you broad advice about that, other than to say that every patient who comes through fertility treatment at Newlife has a consultation with the embryologist at the time of embryo transfer. If there are issues with embryo development, we arrange feedback with the embryologist. These are the scientists who look after the embryos. And we always make sure that you have another consultation with your specialist to go over what are your options for subsequent treatment. We're very proud to have really great fertility nurses and really great psychologists working with us at Newlife IVF, and we always try and involve them in the care of patients who have outcomes that need to be worked on. And we think it's really important to help you emotionally as well as scientifically and medically. Once you're pregnant, there can be issues. Like any pregnancy, you can have a miscarriage following IVF. You can have an ectopic pregnancy. So it's really important that once you're pregnant, your treatment with Newlife is not finished. Your fertility specialist will continue to care for you for the first few weeks after your pregnancy until your care is taken over, until such time as your care is taken over by an obstetrician. Once you get past the initial stages, we do consider IVF pregnancies to be of higher risk than others. And therefore, we always recommend that you have care by a specialist obstetrician, and ideally a specialist obstetrician who's used to dealing with women who are pregnant through IVF, because that's not always it's not a common skill. We do know that in some circumstances, particularly with frozen embryo transfers, there's a little bit more preeclampsia during the pregnancy. So it's very important to be on the lookout for that. We know that there is there's higher rates of growth problems for the baby during IVF pregnancy, and having a placenta that grows low in your uterus close to the cervix is a little bit more likely too. Nonetheless, we don't want to be panicked about it. All these things are manageable, but you've really got to be considerate of these issues when you're going through your pregnancy. The last thing is twins. And twins, we routinely recommend transferring only one embryo at a time. So whilst you do hear that twin pregnancies are much more common when you've undergone IVF, usually it's because two embryos have been placed back in your uterus rather than one. So we're confident that by doing a single embryo transfer, we really do minimise the chance of twins. So, burning question: how successful is IVF? And that's it's such an easy question, but it's such a hard question all at the same time. And that's because the chance of you getting pregnant and having a baby from IVF is really dependent on your individual circumstance. And the factors that are really key are, number one, age, followed closely by your past fertility history, whether you've got good egg numbers, whether you've got low egg numbers, whether your sperm's good quality, poor quality, bad quality, all those things go up. So it really has to be, it's a question that really does need to be individualized. The next difficulty is there's lots of different definitions of what an IVF pregnancy is. And some people, when they're talking about their success rates, they talk about clinical pregnancies. Now, a clinical pregnancy is when you do a pregnancy test, like a urine pregnancy test. If it comes back positive, that's a clinical pregnancy. That is a very different thing, though, to a live birth. So a live birth is when you go through the whole pregnancy successfully and then take home a baby. The difficulty is with clinical pregnancies, you can still have miscarriages, you can still have ectopic pregnancies. So there can still be issues. So sometimes using clinical pregnancy as opposed to live birth rate is a little bit, it can be a little bit misleading. Sometimes when people talk about success rates, they talk about the pregnancy rate per cycle. So versus per transfer. And that's a very different thing as well, because per cycle might mean per egg collection, which means if you have your egg collection and have 5 embryos and then sequentially have them transferred, that's clearly going to lead to a very much higher pregnancy rate than if you're just comparing that to the pregnancy rate per individual embryo transfer. So it can be confusing and it can be misleading. And you therefore ask the question, can clinics be compared on the basis of statistics and pregnancy rates? And I think in the current climate, it's very difficult. There's no standardised reporting in Victoria that allows patients to really accurately assess the quality of an IVF clinic. We would be very welcome to standardised reporting. We think it's something that must occur in the near future, because it's going to be really helpful for patients making the decision about where they should undergo their treatment. But at the moment, it's quite difficult. The pregnancy rates I'm going to talk about now are pregnancy rates across the whole of Australia. So these are not specific to Newlife IVF, but it gives you a bit of an indication as to what pregnancy rates we see out there. And this little graph looks at the pregnancy rate per embryo transfer. So if you've got one embryo and put it inside your uterus, what is the chance of pregnancy? So the little bar on the left is the clinical pregnancy. What's the chance that you will have a pregnancy test that comes up positive and an ultrasound seeing a pregnancy, versus the column on the right, which looks at what is your chance of taking home a baby. As you can see, there's a little bit of a drop-off between the clinical pregnancy rate and the live birth rate, and that's because some people have miscarriages. So the more meaningful result is probably the one on the right, and per embryo transfer in Australia, across all age groups, it is just over a 25% chance of pregnancy. If you then broaden your definition and say, what is the pregnancy rate per egg retrieval? So Amber talked before about how you take your eggs out and then grow the embryos in the laboratory. And you might have 1, you might have 2, you might have 3, you might have 4, or you might have none. Having said all that, what's your pregnancy rate per egg retrieval once you've transferred all your embryos? And the clinical pregnancy rate has now increased, and it's just above 40%. And the live birth rate has increased as well to just under 35%. So if you consider transferring all of your embryos, you do end up with higher pregnancy rates, obviously. The biggest determinant, though, of pregnancy rates is going to be the age of the egg donor or the woman who is undergoing IVF treatment. And as you can see, women less than 30 have a much higher live birth rate per embryo transfer than older women. As you can see, between 30 and 35, it doesn't make a big difference. So if you compare those two groups, not a huge difference in pregnancy rates. But once you do go past 35, we see a significant drop-off. And once you go past 40, we see a dramatic drop-off. So what this slide tells you is that if you're going to undergo IVF treatment, it's better to do it earlier rather than later. So that's the conclusion of everything we wanted to talk about today. So what we might do now is take some questions. So I might invite Amber back up.
Okay, so the first question is, can I put more than one embryo back into the uterus in a cycle? Well, certainly that used to be very common. And over time, we have, in order to reduce the frequency of multiple pregnancy, we have standardized the way that we do transfers to universally using single embryo transfers. And the reason for that is that a multiple pregnancy is a much higher risk pregnancy, and there's a significant amount of morbidity or complications or unwanted outcomes that occur if we increasing the chance that you'll actually have twins as opposed to a singleton. However, there are some circumstances where you may have had multiple cycles, or especially women with not many eggs, not many embryos, and also older women where the chance of the IVF, the cycle success is very low. We may in some circumstances negotiate to transfer to embryos, but most of the time we would be trying to stick to a single embryo transfer.
Thank you, Amber. So the next question is, how effective is introducing clexane and dexamethasone into an IVF treatment when you've had multiple miscarriages? Wow, what a question. So recurrent miscarriages, gee, that's a whole other talk. But to answer your question directly, the role of clexane is really if there's been a thrombophilia diagnosed in the investigations that you've had looking at why you're having miscarriages. So when you've had some miscarriages, often doctors will do a number of tests. And if those tests reveal that your blood is too thick, too clotty, then it might be that clexane is a useful treatment for that. Then the question becomes, when do you start it? Do you start it at the time of embryo transfer? Do you start at the time of a positive pregnancy test? Do you start it once you've seen a heartbeat? That's a little bit individualised to the particular patient, but my feeling is it doesn't make a difference to the actual success of the IVF, but perhaps there's a role of it in some patients in reducing miscarriage. Dexamethasone, on the other hand, there's no evidence to suggest to support the use of dexamethasone in reducing miscarriage. Some people have used it over the years, either dexamethasone or prednisolone as a treatment for natural killer cells, but that is quite a controversial topic. It's unclear whether natural killer cells are in fact implicated in miscarriages at all, let alone whether they are treatable with steroids. My concern with using dexamethasone and prednisolone in the first trimester is that there is an increased rate of fetal abnormalities. So you would have to be very, very careful and be confident that there was a real benefit in using it to accept that increased risk during the first trimester. So I'll move on to the next question. I might put these next two together. So the first is, what is the ideal number of eggs to get in an IVF cycle? I heard it can be dangerous to get too many eggs. Indeed, and that's what we were talking about before when we were talking about prevention of ovarian hyperstimulation syndrome. So that's a situation where too many eggs are collected and it can make the woman quite unwell. So you are right, it can be dangerous to get too many eggs, particularly if that's not identified in advance. Your question is a good one. What's the ideal number? We generally like to get somewhere in the vicinity of 12 to 16 eggs. That seems to be a nice balance between a good number of eggs, not too many that it puts you at risk of hyperstimulation, but certainly not too few that it makes it harder to become pregnant as a result. Generally, from a pregnancy point of view, the more eggs, the better. So we like to get a reasonably high number. The next question, which is a little bit similar, is, does IVF waste my eggs? And I can confidently tell you that IVF does not waste your eggs. So eggs within your ovary are all at different stages of development, but women have generally have a number of eggs available at any one time. So when I say we like to collect 12 to 16, if you were trying to get pregnant naturally, the month that we collected 12 eggs, for instance, only one of those eggs would have been released. The remaining 11 would have just disappeared and died within the ovary. So in fact, by undergoing IVF, you're actually utilising eggs that otherwise would have undergone, would have just disappeared and never been able to be used. So it's certainly not a waste of eggs to undergo IVF. So the next question, during stimulation cycles, what treatment options are available for people who are at higher risk of hyperstimulation? And in this case, is a fresh is a fresh transfer recommended? So just the first part of that question first, what are available for people at high risk? So the first thing is you've got to choose the dosage of your stimulation drugs very carefully. Again, it's a tightrope. We're always walking that tightrope between wanting you to have a good outcome with egg numbers, but not pushing you over the edge and getting you hyperstimulated. So that's the first thing, is have a specialist who is experienced in appropriate dosing during your IVF cycle. The next is we always do ultrasound monitoring during the cycle, so we should be able to predict with a reasonable degree of accuracy how many eggs are likely to be collected. If it is a high number, we would then use a different trigger called, generally we use decapeptyl instead of Ovidril. And what that means is the eggs can be collected beautifully, but you can't get hyperstimulation. You must freeze your eggs if that's the case, the second part of your question is, is it safe to have a fresh embryo transferred? Well, it depends how many eggs you've collected. So sometimes, in some circumstances, we're surprised by the number of eggs at egg collection. We haven't used the decapeptyl trigger, and then we have to make that difficult decision as to whether we transfer the embryo fresh or whether we freeze them all. I think it's generally better to err on the side of caution and freeze your embryos rather than undergo a fresh transfer, but every doctor would have a slightly different view on that. The reason I say that is frozen embryos do so well when they're thawed out and transferred at a later date that you could make a compelling case for freezing all your embryos anyway, regardless of whether you're at risk of hyperstimulation. So if there is that risk there, it's probably best to freeze them all. I'll invite Am back now.
So there's another question about dual embryo transfer, and the question is, does Newlife allow 2 embryos to be transferred at the same time? And so just to clarify and extend on what I previously mentioned, that we would usually aim for a single embryo transfer, but under certain circumstances and with appropriate counselling and discussion of the pros and cons, it would be allowed under certain circumstances. Okay, then we have a question. Do you recommend laparoscopy to check internally that there are no issues before proceeding to IVF? This is really patient independent. It depends on the suspected etiology of the subfertility. Often in the workup for identifying the cause of the difficulty conceiving, you will have had a laparoscopy as part of that investigation. If the cause is otherwise clear, like if it was male factor fertility exclusively, for example, then having a laparoscopy prior to IVF would not be mandatory, but it is often performed, definitely.
So the next question is, we've got lots of questions tonight. They're great questions. We're just going to keep going through them. I've heard that there is a short and a long IVF cycle. What is the difference? So tonight we presented the most common IVF cycle, which is the short cycle. And you might remember Amber saying that there were 2 types of medication used. One is the medication that gets the eggs to grow. The other is a second medication that blocks ovulation, keeping the eggs inside the woman's ovary so that we can collect them safely. So the long cycle is using a different medication to keep the eggs inside the woman's ovary. And what it involves is starting medication in the month prior. So whereas with a short cycle, which is what we described tonight, everything starts day 2 of the period. With a long cycle, a medication to block ovulation starts a few weeks prior to that. Generally, we get similar. There are some groups that do a little bit better with a long cycle. Generally, though, for convenience and efficiency, most IVF cycles are the short cycle. Next question: if normal fertilisation doesn't happen, as in the sperm doesn't fertilise the egg, can you then change course immediately and do ICSI? And just to elaborate on that question, what the question is about is, on the day of egg collection, we put the sperm with the egg for conventional IVF, and then we check the next day to see if the eggs are fertilised. So what the question is, if when we check the next day and the eggs have not fertilised, can we then do ICSI? The short answer is no, unfortunately not. And the reason being that by the time you've waited that extra day, the eggs have gone beyond the stage of maturity where they will accept the sperm and start the division process. So that can't be done, unfortunately. Do you fertilise all collected usable eggs? Yes, we do. Unless for some reason the patient wanted to store some eggs, but that would be a very unusual circumstance. Absolutely, we do. How long can frozen embryos survive for? So once frozen, indefinitely is the answer. So from a scientific point of view, once the embryos are frozen, they're in great condition, they don't change. It wouldn't matter if it was 5, 10, 15, 20, 100 years. Those embryos will be in perfect condition at the time that they're thawed. The more realistic question is, how long are you allowed to keep them for? And in Victoria, initially when your embryos are frozen, they can be kept frozen for 5 years. After 5 years, you have to recommit to wanting to use those embryos. And that's a very straightforward task. You just get contacted by your IVF clinic. They say, do you still want your embryos? You say, yep. And they keep them for you for another 5. So you can theoretically keep them indefinitely. But the reality is, once you get to 5, 10, 15 years, most people are beyond the stage where they need their embryos, and they tend to be discarded at that stage.
The next question is the trigger injection done at home? And yes, usually the trigger injection is administered around 9 o'clock at night, give or take an hour or two, depending on the scheduled time for the egg retrieval. The trigger injection is very similar to the method of administering the other hormonal injections that you've had during the stimulation phase. So you should be able to do that without any trouble at home, 36 hours before your scheduled egg retrieval. The next question is about whether or not dye studies and laparoscopy is going to be allowed with the latest announcement for the government today. Now, it's unclear the details about the government announcement. We think that this is going to be okay in the coming weeks. Essentially today the government has announced that all category 2 procedures are going to be able to proceed, and that a select number of category 3 procedures, which includes all IVF procedures or all ART procedures, will be allowed to proceed. So without knowing any more details from what the government has announced today in their press conference, we are expecting that we will be able to resume things like dye studies and laparoscopy.
All right, so a few more questions. Generally, how many eggs do you successfully collect? Well, our figures across all women undergoing an egg collection are that we collect between 9 and 10 eggs. So that's about the average amount. We have a hugely wide range. Some patients collect 30 or more. Some patients, we go to an IVF cycle and collect 1. So there is a wide range. If having frozen embryo transfer, will you still ovulate that cycle, and would this increase the chance of twins? So if during the frozen embryo transfer cycle that I talked about tonight was one in which the patient does naturally ovulate. So yes, it is possible that you could get pregnant from that naturally ovulated egg. Then a few days later, you come in and have your embryo put in and you get pregnant with that one as well. So yes, it is possible to get a twin pregnancy. It's whether it's literally possible really depends on the reason you're having the IVF. If you've got blocked fallopian tubes, I guess you could say that effectively means that's not possible. If you had very low sperm count, I guess that makes it quite unlikely. But at the end of the day, it only takes 1 sperm sometimes. So the short answer is yes, it is possible, but we don't see a lot of twin pregnancies that are a result of that happening. So does this mean your patients generally all have private hospital gold cover insurance? So no, mostly they don't. So what this question is about is whether private health insurance covers IVF treatment. And the funding of IVF treatment is reasonably complex because there is lots of elements that go into it. Medicare, which the vast majority of people living in Australia have access to, pays the vast majority of the fees for IVF. The component of treatment that a private insurer will pay for is when you come in and have your egg collection, you must be admitted to a private hospital to have that done, and you need an anaesthetist, a specialist anaesthetist, to manage your sedation whilst you have the procedure performed. And the health insurer will usually cover those 2 fee components. You are right to identify that gold cover insurance covers it, whereas silver and bronze do not cover IVF treatment at all. So if you do want to have private health cover that covers you for IVF treatment, you do need gold cover insurance, and it does make it does reduce the fees by a substantial amount if you do it. Generally, that amount is in the vicinity of about $1,500. So for obstetrician monitoring after successful IVF, it doesn't that mean without private health insurance is super expensive? Having a baby in a private hospital without private health insurance is prohibitively expensive for the vast majority of people. And the reason for that is that the private health the fees that a private hospital charges patients to be admitted are very high, and generally in the vicinity of about $5,000 to $7,000. So it is quite expensive having a baby in a private hospital unless you have that cover. All right. So that is all we have time for tonight. But thank you so much for joining us. Whilst there's still some uncertainty about where we're at from the fertility treatment point of view and from the elective surgery point of view, our feeling is that we're very close. And like I mentioned at the start, if you're ready to start treatment, do let us know, because we feel that we are ready to start offering IVF treatment again. But if in any doubt, contact Newlife IVF, contact your specialist, particularly talking about elective surgery, contact your specialist, because they will have up-to-date information about their particular hospitals. In the meantime, look after yourselves, look after your families, look after your mental health. We are always available to help you at Newlife IVF. So if you are having difficulties with the current situation, please contact us. We've got fertility nurses, we've got counsellors standing by who are used to helping our patients during difficult times, and which we are certainly all experiencing at the moment. So thank you very much for joining us tonight. I hope you found it informative and maybe even entertaining. But we'll be back next week with another webinar, looking at fertility treatment in same-sex couples, the real modern family, I think we've taught it, and also looking at fertility treatment in single women. So again, thank you so much for joining us, and good night.